So hello everyone, and today we'll be discussing a spotter. So here we have a 70-year-old male who presented with severe dementia and urinary incontinence, and this is the axial section CT scan, non-contrast, where we can see that the ventricles are dilated and the sylvian fissures and the sulcal spaces are very prominent, which represents generalized involutional changes, age-related. Other than that, the third ventricle is also dilated, and the callosal angle, which is measured in coronal sections, is also acute in this particular case. The Evans index was also increased, and in keeping with the history, it was suggesting normal pressure hydrocephalus (NPH). So this is a report that was given that there was mild generalized brain atrophy, along with the lateral and the third ventricles were dilated compared to the sulcal pattern, and the corpus callosum was displaced upward. The callosal angle was reduced between 50 to 80 degrees, and the Evans index was also increased to 0.5, which indicated the possibility of normal pressure hydrocephalus. So what exactly are the features of NPH? So it is actually remembered by the mnemonic wet, wacky, and wobbly, which includes urinary incontinence, cognitive impairment, and gait disturbances in the form of magnetic gait. So then coming to the imaging features of normal pressure hydrocephalus, the first feature that we have to look for is ventriculomegaly. And the objective way to see whether there is ventriculomegaly or not is Evans index. Evans index is actually the diameter of the ventricles divided by the diameter of the skull, inner diameter of the skull, which if more than 0.3 is indicative of ventriculomegaly. Then there is something called AVLI, that is antero-posterior diameter of the lateral ventricle index, which is calculated by antero-posterior diameter of the ventricles divided by the inner diameter of the skull. When it is more than 0.5, it is suggestive of ventriculomegaly. Then there is widening of the temporal horns of the lateral ventricles more than 6 mm. And then there is acute callosal angle, which is actually measured in the coronal sections. The angle should be measured at the coronal image perpendicular to the anterior commissure posterior commissure plane at the level of posterior commissure. So this is actually the callosal angle, which if less than 90 degrees indicates ventriculomegaly. And then there is upward bowing of the corpus callosum, which is seen on SAG images. The second imaging feature is disproportionate changes in the subarachnoid space. That is dilated sylvian fissures, insular cisterns, effacement of the sulci and the subarachnoid spaces at the vertex and the medial and paraphalci region. Then there is something called cingulate sulcus sign, where the posterior half of the cingulate sulcus is narrower than the anterior half of the cingulate sulcus. We can see this in this image, cingulate sulcus sign. So the third thing that we have to remember is that combination of ventriculomegaly, sylvian fissure, and insular cistern widening is termed as disproportionately enlarged subarachnoid space hydrocephalus. And when this is present with no symptoms and is seen on MRI, it is termed as asymptomatic ventriculomegaly with features of idiopathic normal pressure hydrocephalus on MRI, that is AVIM.